disorders in children. For their turn to talk. They may not know how to start talking or how to end a topic. So this is what we say are kids that are called picky eaters or fussy eaters, who may hold their food, take 1 hour to eat, all those things. Fluency disorders is stammering, like it's called in India. It's called stuttering in the US, same thing. And hearing disorders. So a speech therapist basically assesses what a child understands. That's called their receptive language. What the child says, that's the expressive language. The sound development. So like I said, when a child says tat for cat, you see what sounds they have, what sounds they don't have according to their age. And the child's oral motor status, which is how the lips, tongue, palate, all of that. Like a child could be drooling because all this muscle tone could be like low. So that's what a speech therapist assesses. So for parents, red flags that they should watch out for is if their child is difficult to understand, if their child is not using and pronouncing words clearly, if they're consistently using incorrect grammar, if they don't hear or understand well, if they have very loud speech, because that could also mean that they have trouble hearing, if they are disfluent, or if they're not talking when they should be. So by about age 2, 50% of what a child says should be understood. And by 4, 100% of what the child says should be understood by everyone, not just the family. So this is just a chart of like normal speech and language development. By 3 years, and this is more by late 2, you expect the child to understand and speak about 50 words. They should begin combining 2 words together, and they should be able to follow 2-step directions. And by 4 years, there should be this big explosion in vocabulary. You see new words being added every day. They should have long sentences, 3 or more words. They should understand prepositions. They should understand colors and size concept. So all this should come by 4. Sometimes in India, people expect it a little earlier, but the normal age limit is 4. So the disorders that we'll cover in more detail are feeding issues, voice, stuttering, traumatic brain injury, attention deficit hyperactivity disorder, and autism. Okay. So dysphagia is the medical term for swallowing and feeding problems. You also see dysphagia in adults post a stroke or any sort of brain injury. But in children, it's more feeding issues. So many times family members say that the child will outgrow it, or they will eat when they're hungry, or leave them alone, they'll figure it out. But children with feeding issues, even if you keep them hungry for 5 days, they won't eat. So they'll fall asleep crying, but they won't eat. So it's usually seen in children who've had some sort of medical history when they were younger, either reflux or something like that, which makes them feel that their mouth is very scary and unsafe. So when you try and feed them, they get this like hyperactive gag reflex and then throw out everything that's gone in.
Happy to God get out of it, I feel.
Sorry?
I feel happy to get out of it.
They're happy to get it out,
No,
yeah.
I'm saying as a father.
As a father?
Yeah, happy to get rid of it.
So I didn't get it, sorry?
I also had a kid.
Huh.
I never had problems like this.
Right. But it's very common now. It's very common. I mean, people are taking 1 hour to feed their children, and no one has 3 hours in the day to keep aside for feeding. So it's become very, very common. And again, the earlier you detect it and you address it, the faster and easier it is to kind of work through. So when I work with kids who are 1.5, it's a lot easier than when I work with a 5-year-old who's not eating. So, because by the time they're 5, they've decided they're not going to have it. So you can do what you want. So the red flags are, like I said, kids who've had reflux, and if they're congested during and after feeding, And if they're choking or gagging while being fed. In a young baby, they may have trouble sucking from the bottle. They may get tired before even like finishing feeding. They may take too long. A lot of kids who have feeding issues as young kids may, as all other kids, put things in their mouth, put toys in their mouth. These kids may skip that entire phase, like they don't put stuff in their mouth at all. And sometimes they may have mashed food, but they refuse to have anything that's harder, anything that's chewier. So that's what we say, refuse to advance textures. They don't like to get messy. If something like falls this much also, they'll be like, wipe it, wipe it, wipe it. So, or they may vomit. That also happens. It happened a lot at my clinic. So that's pretty much the feeding issues. Pediatric voice disorders is seen in 5% of school-age kids. It's mainly because they yell a lot when they're playing on the playground. And usually some amount of yelling is okay, but when their voice sounds like it's consistently hoarse, like it's consistently gone, that's when there could be a bigger problem. Their vocal cords could be swollen, they could be red, usually seen in boys, again between 4 and 9. And if they continue doing this, it continues getting red and swollen, it eventually leads to vocal nodules, which is the growth of the swelling area on the vocal cords. The nodules can be treated with speech therapy through exercises and behavior changes. If the nodules persist, then they have to be surgically removed. So if they get like hard and swollen, then they have to be surgically removed. The next disorder is stuttering or stammering. So the exact cause of stuttering is not yet known. They do say it has a genetic basis. It's usually seen between 2 to 5 years of age. That's when it develops. Stuttering that develops in adults later on could be due to some sort of brain injury or whatever, and that's called neurogenic stuttering. That's completely different from developmental stuttering. And they say that many factors, like environmental factors, don't cause the stuttering, but they kind of make it more noticeable because the child already has a predisposition to stutter. So many times parents will say, you know, his school changed, or we moved, or the teacher was strict, but that didn't cause it. That kind of just made it worse, made it more noticeable. It would have shown up at some point anyway. So some facts. 1/3 to 2/3 of people who stutter have a family history. It's 3 to 4 times more common in boys than in girls. And it's more prevalent in bilingual speakers. So when should you initiate treatment for stuttering? You usually initiate it when you see the stuttering for over 3 months.
You mean a lot of kids go through this?
So what happens is with stuttering, usually a lot of kids go through this pattern which seems like stuttering when they are between 2.5 to 3.5, because that's what we call a system. I'd say about good 40-50%. But that's what we call, that is called, because there's a system overload. So at that time the child is learning new words, they're learning motor skills, they're learning running, coloring, all of that. So the speech goes through this like hesitating pattern. About 85% of those kids grow out of it on their own. So the ones that don't need treatment, but to know when they need treatment is if it lasts for more than 3 months. So in children, how stuttering is usually seen is that there are cycles of fluency and disfluency. There'll be like days when the child is stuttering on every word, and then there'll be days when there's nothing. So if that whole thing lasts for about 3 months and you're still seeing it, then you should start treatment. And if there's a family history, definitely you should not wait at all, just start treatment. Tension and struggle is basically if the child is tightening any muscles over here when they're speaking, that's what we call tension. You know, they're like, you see their mouth staying open, they're trying to get the word out but nothing's coming out, and then again they try, so that's struggle. And if there are other speech and language issues present, or if the child himself is concerned and say, why am I talking like this, then they should be taken to a speech therapist. I usually see kids for stuttering not before 4. I wait till about 4 to see if they are going to spontaneously recover or not. Because 2.5 to 3.5 is when we usually expect it. Some of them outgrow it. So by 4, if they don't, but if there's family history present, then I start earlier. But it's hard to kind of do direct treatment with a younger child for stuttering. So I teach the parents on how to kind of mold their life differently at home if there's a family history present. So why not to wait for therapy is because more negative reactions are apt to develop. So when stuttering starts out in a child, it's purely a speech problem. But what happens is when kids grow up and they start growing up with the stuttering, they start developing feelings of, okay, I'm talking differently and all of that. So then there are feelings that develop. So then by the time the child is older, it becomes speech plus like psychological. But in a young child, it's purely speech. So that's why not to wait. And the longer you wait, the less likely they're going to outgrow it. They're not going to outgrow it beyond 4. And most parents have a gut feeling that they should not wait, and that's usually right. So I would go with that.
But very students, I find very young age, they're very smart, even at 3 months, 4 months.
3 months and 4 months, they're smart.
Very smart.
They're very smart. Like they know everything way before they're supposed to.
I'm very surprised, when you get to see them.
Yeah, and they use a lot of big words, they use full sentences. They're very, very, very intelligent. So yeah, our next area is traumatic brain injury, which is also called TBI. This is kids who've gotten into accidents and post-accident. They have a whole host of issues. They may be in coma, but after they do come out of the coma, they may have a loss of memory. Usually that's the short-term memory. So they remember all their old stuff, but they can't retain any new information. They may lose smell, taste, all of that. Writing, buttoning, wearing their shoes, all of that by themselves may be difficult. Eating by themselves may be difficult. Their muscles get what we call dysarthric. That's a lack of muscle tone. So their speech sounds like they're kind of sleepy, like a drawl. They may have word finding issues, so they may be able to talk, but like specific words may be very, very difficult to come up with. So like they'll be like, that thing that we used to go to, like they can't remember the name of it. And they may have dysphagia, which is swallowing difficulties, because all these muscles lose tone and the swallowing mechanism kind of loses timing. So that may happen. And they definitely go through a lot of emotional changes. So there's a lot of frustration, impulsivity, constant anger, and things like that. So speech therapists work on the memory bit, they work on the dysarthria bit, the word finding, the dysphagia, the oromotor skills. All of that's covered by speech therapy. But usually someone with a traumatic brain injury requires all 3 therapies: speech, occupational, and physiotherapy. Okay, so this one's pretty popularly diagnosed and misdiagnosed. ADHD, or attention deficit hyperactivity disorder, is the child, what they're thinking in their head is, I understand everything you're saying, but I just can't do it, because they cannot pull everything together to focus at that point and do the task that they're supposed to do. So if you give these children something written, they're understanding it. Even when you say it orally, they're understanding it. It's not like they're not. But they can't complete the task because they just can't pull it together for a long period of time. So it mostly very, very, really affects their academic performance. So they're easily distracted. They're unable to complete the tasks. They're impulsive. So kids with ADHD may, when they're younger, just throw things or whatever because they think after they do it. They are unable to pay attention, even when you keep redirecting them to the activity. They have difficulty following directions. They have poor organizational skills. So, as they grow older, they may need help on, how to plan, like when they come home from school, homework first, then this, then that. That ability to plan is tough. So they may wake up at like 10 o'clock in the night and realize they've not done their homework. And they tend to lose things. They tend to be clumsy. They forget things frequently. And when they're younger, they also exhibit signs of stubbornness, temper, defiance, all because they're following what's going on, but no one's giving them the time to kind of do it. So, we expect things to be done really quickly, and they can't keep up. Their attention can't keep up with it. The last disorder that we're going to cover is autism, which is also called ASD, Autism Spectrum Disorders. It's become recently extremely, I would not say popular, but very prevalent. It's the US statistic is now 1 in 66 children are being diagnosed with autism. It was always there. It's just the diagnosis of it has become a lot more accurate. And some facts about it. It's developmental. It originates prior to birth or in early infancy. It's neurological with genetic components. And you diagnose it, there's no medical or genetic examination. You have to do it through specific behavioral analysis. And it's not called autism anymore, it's called ASD, Autism Spectrum Disorders, because every child with autism is completely different and their skills vary from you have children with autism who are non-verbal, you have children with autism who are completely verbal, going to college and all of that. So it's a huge spectrum. It has a triad of symptoms. You say it's an autism spectrum disorder when there are social impairments, communication impairments, and behavior issues. So the social impairments seen in children with autism is the biggest is difficulty using non-verbal behaviors and also understanding non-verbal behaviors. So these kids don't understand, say for a child, if you want to make big eyes, that means that okay, they should stop what they're doing and sit down. But for a child with autism, it's difficult for them to pick up on that. They may not pick up on a change in facial expression. They may not pick up on a change in eye gaze until you actually use the words and say, stop that. They may not get those subtle changes. And they themselves are not able to make those changes. So they tend to sometimes look kind of like they have one expression. They have difficulty forming peer relationships. They tend to kind of like to play on their own. They may like some kids, but they will particularly like only then those kids, and they won't usually mix with a larger group. They have difficulty seeking out others for the purpose of sharing enjoyment and interest. They tend to focus on their own interests. And they have difficulty with the back and forth nature of relationships for social or emotional purposes. So for a young child, this is, how kids like to show off and show their parents what they've done and what they've achieved. A child with autism may do as well, but they don't go with that back and forth of showing and then someone saying wow and then they're feeling very proud of themselves. So, and they lack variety and spontaneity in make-believe play or social imitative play. So less of this creative play, less of play with dolls, less of play with, oh, look at what I made and this is this and this is that. They tend to play with things that are more concrete, more like blocks and things like that, which is more visible instead of imagining things. In their communication impairments, they usually have a delay in speaking, so they usually talk late. When they're a little older, they have difficulty starting or maintaining a conversation. And sometimes they tend to get stuck on their own areas of interest and will only talk about that. And their language then tends to be a little repetitive. Their behavior impairments are, they may be preoccupied with an interest. And this could be anything. They are slightly inflexible and they like to stick to a routine. So when you change that routine around on them, they get extremely upset. And some children, again,
This is at what age you're talking?
this is by, yeah, this is by you'll see it by 2.5. I mean, the conversation around won't come in at 2.5, but just inflexibility, that definitely comes in. And some children may use repetitive motor movements or stereotype movements, as they may flap their fingers or things like that, stare at their fingers. But again, it's a spectrum. There are children who have none of that and seem like they're totally functional, but they still may be diagnosed with autism. So to end, basically what I just wanted to point out, that early identification and treatment is the key to prevent a speech and language disorder from becoming a lifelong disability. And that's completely true. The younger kids that I work with show faster and better improvement than kids who are kind of more set in their ways and start much later. And that's it.
Yeah, I have a question.
Please.
Mainly regarding this autism.
Mainly regarding?